Dr. Eric Crable. I'm a bariatric surgeon and the medical director for bariatrics at the North Ottawa Community Health System. Today I'll be discussing our surgical orientation and describing the surgeries that we provide, as well as any details that you may have wondered about what to expect from your weight loss surgery and what the recovery process may look like. It is shown to demonstrate that we are an accredited center and participate in the quality program set forth by the American Society for Metabolic and Bariatric Surgery. What this means is that we follow all protocols that have been set forth to ensure that we provide the quality care that you expect as a patient, and this in turn typically results in greater outcomes. Body mass index, or BMI, is a number that we utilize to determine whether or not you are a potential candidate for weight loss surgery. What this is a ratio of your weight versus your height, and you can simply enter your values into a calculator on the internet to determine what your BMI number is. Important numbers that we'll discuss later on in the talk are BMI of at least 35 or BMI greater than 40. You'll see that if your BMI is between the numbers of 30 and 34.9, this would categorize you as obese. If your BMI is 35 or greater, this is considered morbidly obese. Looking at these maps of the United States, with the last one shown from 2015, shows the overall increasing trend of self-reported rates of obesity in adults throughout the United States. You'll see that Michigan is listed as one of the states with a self-reported BMI considered obese at a rate greater than 30%. More recent numbers and data show that approximately 39 to 40% of the adults in the state of Michigan would consider themselves obese. Obviously, this is an ongoing worsening trend that we hope to do something about. And the options that we provide with regards to weight loss surgery can significantly help this. Medical comorbidities. These are oftentimes associated with obesity. And the four most important ones that we hope to potentially eliminate from your list of diagnoses are things like diabetes, which is typically type 2 diabetes or adult onset, sleep apnea, high blood pressure, and hyperlipidemia. You'll see the other diagnoses listed here are as well associated with obesity and can be greatly helped and even eliminated by losing a significant amount of weight. What are our surgical goals? The first bullet point listed there is to improve your health. We're not in this to achieve or focus on the numbers necessarily. We do want to help you lose the weight because by doing this, we can treat those comorbidities that we showed on the last slide. By doing so, we'll decrease your risk of early death. Hopefully improving your quality of life amongst all aspects of your life, your personal life, social life, and even something as simple as performing your work tasks and duties. And we want to help you sustain this weight loss. So we're not in this for the quick fix. We don't want to perform an operation and send you on your way. We're here to help you throughout this process, and where the most of the work comes in is in the post-operative period. And follow up, keeping your appointments with the medical providers that we have right here on site are going to help you become successful. Unfortunately, surgery is not a cure. What it is the best weight loss tool that we can provide you. Using this surgery, along with proper nutrition, exercise, and including a support network. This may involve family members, friends, even people that have had previous weight loss surgery. These are your motivators as well. And being personally motivated is going to hopefully equal greater success overall. The more committed you are to this process, hopefully the more weight you can lose and the healthier you can become. The National Institutes of Health, or NIH, is the organization that sets forth the criteria for weight loss surgery. If you have a BMI between 35 and 40 with at least one obesity-related medical condition, or comorbidity, such as high blood pressure, high cholesterol, or sleep apnea, or simply a BMI greater than or equal to 40, this would qualify you to have a weight loss surgery or bariatric surgery. Typically, you also have to demonstrate that you are psychologically capable of tolerating the changes that surgery will provide you with. And most times, you'll have to demonstrate a previous attempt at medical weight loss. And this comes into play when we discuss which medical insurance you have and what the insurance criteria are specifically. Because all policies are different, and all preoperative attempts at medical weight loss may vary in their time frame. What this oftentimes will entail is a medical weight loss program that includes exercise, dietary training or teaching, behavioral therapy and support, or commercial diet programs may suffice as well, such as Weight Watchers or Medical Weight Loss Clinic. Oftentimes, patients that are considering surgery may have tried pharmaceutical supplements with physician supervision as well. We do provide a strictly medical weight loss program here at North Ottawa Community Health System as well through our Bariatric Clinic. This can serve as your medical attempt at weight loss if needed, as determined by your insurance company prior to undergoing bariatric surgery. Our bariatric expertise stems all the way back to 1999, where my partners and I started the weight loss surgery programs in Grand Rapids, and we are based out of a company called Grand Health Partners. Through this, we've offered individualized care amongst the 3 surgeries listed below: laparoscopic vertical sleeve gastrectomy, laparoscopic Roux-en-Y gastric bypass, and the laparoscopic duodenal switch, which we'll discuss later. This slide outlines the entire process from start to finish for bariatric surgery, beginning with the surgical orientation. The next step, oftentimes after watching this presentation or attending one in person, will be to have a bariatrician consultation. And this will be done with our bariatrician, Dr. Jennifer Sandy. Oftentimes after this, we, based on your insurance, may need to enroll you in our surgical prep program, and this may vary in its overall length. Preoperative testing will typically be performed, such as laboratory work or EKGs and imaging. Psychological evaluation will be performed by our behaviorist on site. Finally, you'll meet with myself, the bariatric surgeon, in a consultation. At that time, we'll discuss which surgery you are considering and which surgery is right for you based on your current health status and goals. After surgery, the 2-week pre-op dietitian training and beginning our preoperative low-calorie structured diet will be next. After that, we typically see you back in the clinic at 1 week to do a complete physical and check to see how your body's responding to the product that has been started. Following this, surgery will be performed. The vast majority of our patients are only in the hospital one night, discharged home the next day after surgery. Post-op follow-up care will be performed at 2 weeks, 6 weeks, 3 months, 6 months, and then hopefully every year after that to ensure long-term success with your weight loss goals. Laparoscopy. This is the manner in which we perform bariatric or weight loss surgery. By doing this, we typically perform all of the surgeries that were previously listed through 5 small incisions. 4 of them measure only 5 millimeters, or half a centimeter in length. The largest is typically 2.5 centimeters, or approximately 1 inch. By doing the surgery in this manner, we can typically see our patients have less pain, shorter stays in the hospital, and overall quicker recovery. Because we are performing these smaller incisions, there are typically smaller scars. There's a much lower risk of hernia formation and a very low risk of infection. The chances of us needing to convert from a laparoscopic to a traditional or open surgery are much less than 1%. The following slides will discuss the 3 surgery options that we provide. We'll begin with the vertical sleeve gastrectomy. We'll see this surgery is performed by restricting the overall size of the stomach. And by doing this, we staple off approximately 75 to 85% of the stomach of what we call the greater curvature. By doing this, we also eliminate a significant source of hunger. We have a hunger hormone called ghrelin that is situated in the uppermost part of the stomach that is removed. This is a hormone that circulates through the bloodstream, oftentimes shortly after or in between meals, that tells our brain that we're hungry, that we need to eat more and more often. By removing this stimulus, most of our patients after having the sleeve gastrectomy will experience much less hunger and in turn not be able to eat as much at any one sitting, given the overall decrease in size of their stomach. Most patients can hope to lose 40 to 70% of their excess weight, or EWL, at 18 months after surgery. You'll note when you look at this image compared to the following two, the operation is performed only on the stomach. So we do not touch or operate on the small intestine and therefore can eliminate many of the risks that are associated with it. After having the surgery, everything that you eat and drink will travel down the same path that it does right now. So starting from the mouth, through the esophagus, stomach, and then through the rest of the small and large intestine.
The sleeve gastrectomy is a restrictive procedure which limits the amount of food you can eat by reducing the size of your stomach. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure. All surgery presents risks. Weight, age, and medical history determine your specific risks. Ask your doctor if bariatric surgery is right for you.
Looking at the pros versus cons of the laparoscopic sleeve gastrectomy, we see that on the left, the pylorus, which is actually a muscle or a sphincter at the bottom part of the stomach, is left intact, and we do not bypass over this. Therefore, this decreases your risk of potential ulcer formation, which we'll talk more about in some of the other operations that we provide. As the video showed, the absorption of essential vitamins, minerals, nutrients such as protein, carbohydrates, and fats is done primarily in the small intestine. So therefore, we see significantly less or essentially no malabsorption after the surgery. I will tell patients that we oftentimes still want you to take at least a daily multivitamin and oftentimes vitamin D and calcium, since we do live in Michigan and we don't often see enough sunlight to make enough vitamin D in our skin. The shorter operative times can be seen with the surgery as well. I can perform a laparoscopic vertical sleeve gastrectomy in approximately 1 hour. Sometimes this may be altered based on your history of previous operations or if additional surgeries may need to be combined at the same time. You'll see that last bullet point lists that if further weight loss is needed, we can actually convert the sleeve gastrectomy to other weight loss type operations, such as a gastric bypass or even duodenal switch. So by starting with the sleeve gastrectomy, we essentially haven't burned any bridges, meaning we can oftentimes begin with this and then convert to other operations if needed for additional weight loss or even for complications down the road. The cons, we still list questionable durability, and that's because the sleeve gastrectomy has become the most commonly performed weight loss surgery in Michigan and throughout the United States over the last few years. The gastric bypass, which we'll talk about next, has been performed for a longer period of time, and therefore we have more data to look at its effectiveness as well as the potential risks. So we're still acquiring data from this surgery, but thus far I've seen great results in overall weight loss, as well as increasing the number of healthy years that you have left by treating those medical comorbidities that we discussed earlier. Some patients may see this as a con if you potentially may need a second stage or additional procedure for more weight loss. However, this is actually quite uncommon, and only a few percent of patients will actually move forward with additional surgeries. In the last bullet point list there, as this surgery being irreversible, meaning once we take out or remove that 75 to 85% of the stomach, we cannot replace that. What are the risks? The risk of death is always there, about 0.3%. As we have more and more experience with the surgery, we see this number continue to drop, however. And when we compare, in general, laparoscopic bariatric surgeries, the overall mortality or death risk from these surgeries is significantly less than even more commonly performed surgeries, such as the laparoscopic cholecystectomy or laparoscopic gallbladder removal, by nearly 3 times. Leak can happen. There's a long staple line that is performed during a sleeve gastrectomy, and a leak from that staple line can occur. The 1% number listed is the national average, which again is downtrending throughout the country. Looking at our most recent data amongst myself and my partners in Grand Rapids, Michigan, show our most recent leak rate data at 0.3%. Pulmonary embolism can occur, or blood clot that can happen in the lungs. Oftentimes these blood clots will initially form in the lower extremities or legs and travel to the lungs. This can be a serious event, which is why you'll hear us talk over and over about walking. Lots of activity in the early postoperative period. Stricture or narrowing of the stomach can occur. During the surgery, we actually place a thin, flexible plastic tube that goes through the mouth, down the esophagus, and into the stomach while you're asleep during the operation. And this serves as essentially our template to know exactly how large or new diameter to make your stomach. This prevents stricture. Nausea. This can happen essentially for any operation that's performed under general anesthesia. In addition to this, we are operating on your stomach, and you may potentially need narcotic pain medications for afterwards. These can both contribute to nausea as well. We typically send patients home with a anti-nausea or antiemetic prescription for you to use at home if needed. Food intolerances may occur. This is where the individual nature of each patient may come into play or play a factor. Certain foods patients have noted in the past to essentially just not do well with after the surgery. Common complaints or common experiences are patients that don't do well with really sweet or sugary foods, or even fatty and greasy foods that may cause an upset stomach. Acid reflux or heartburn can occur, and this can happen oftentimes due to the smaller size and thus higher pressure of your new stomach. We see these rates of reflux or heartburn more commonly in the early postoperative setting as your stomach is still healing and the swelling or edema around it is decreasing. However, we do send patients home with at least 6 weeks of anti-reflux medications after the surgery to minimize this as well. Infection can happen as well as bleeding. The risk of a major bleeding event would be on the order of 0.3 to 0.5%. Next, we'll discuss the laparoscopic Roux-en-Y gastric bypass. This is done as primarily a restrictive operation. However, there is a small malabsorptive component, or intentionally bypassing part of the small intestine where you should be absorbing nutrients and food. It's the second bullet point there, like we talked about previously, we may not be able to say that accurately anymore. The sleeve gastrectomy has become the more commonly performed weight loss surgery in the United States. However, we have a long track record in performing this surgery over the last 20 to 25 years. You'll see, looking at the picture on your right, that we create a small pouch of a stomach that is approximately the size of an egg. We also divide the small intestine farther downstream and then reattach this to your new stomach pouch. By doing this, we greatly limit the amount of food and fluid that you can eat at one time, and also bypass a portion of the intestine that can play a role in absorption. 70 to 80% of your excess weight can be lost at 18 months, and most patients can continue to keep this weight off upwards of 50 to 60% at 5 years after surgery.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure.
The pros of a laparoscopic gastric bypass include our long experience, and it being actually the best anti-reflux operation that we can provide, in addition to helping you lose weight. Some patients that may have a long-standing history of GERD, which is gastroesophageal reflux disease or heartburn, may have actually chronic damage to the esophagus. In this case, the gastric bypass may be the better operation to help with your weight loss goals, as well as to help treat the reflux. You'll see dumping syndrome is actually listed as a pro. Some people see it as a con. However, what this is describes the sensation that patients sometimes feel after eating certain types of food. Typically high sugar content or high carbohydrate loads after they're eaten travel directly into the small intestine. When this happens, there can often be an influx of fluid or water from outside the intestines to the inside. And this can result in nausea, bloated sensation, abdominal pain or discomfort, and sometimes even diarrhea. So what this serves as is somewhat of a training or teaching tool for patients to learn to avoid those types of foods that are typically not conducive to weight loss in general, such as high carbohydrates. This surgery is considered reversible. It's a large undertaking to perform. Few patients truly undergo or follow through with this, but it can be done. The cons. Marginal ulcers are a long lifetime risk after having this surgery. Patients that consume large quantities or frequent doses of NSAIDs, such as ibuprofen, aspirin, naproxen, or Aleve, or smoke, or return to smoking after they quit prior to undergoing surgery, can see high rates of ulcers. and the ulcers typically form at the margin or the new connection at the site of the stomach pouch and the small intestine. Ulcers can bleed, they can perforate or rupture, oftentimes requiring emergency surgeries to fix. We also typically like to see patients limit their overall alcohol and caffeine intake, as these tend to play a role in ulcer development as well. We see a small increase in kidney stone formation after gastric bypass surgery due to potentially altered calcium absorption as well. Because of the issues of malabsorption, oftentimes lifelong vitamins are required to supplement intake, and these often include things such as iron and vitamin B12. The complications listed for gastric bypass are similar to the laparoscopic vertical sleeve gastrectomy. You'll see the risk of death or mortality rate and leak rate are roughly the same. Pulmonary embolism or blood clots in the lung is still a risk. The marginal ulcer risk is, however, new when we compare this to the sleeve gastrectomy. The overall risk of ulcers forming in a patient that had a sleeve gastrectomy is roughly the same as your pre-surgical risk. Stricture or narrowing can happen. Other risks that are not listed here are things such as small bowel obstructions or scar tissue on the small intestine after having the surgery, which may require future surgery to correct or to prevent bowel obstructions. Bleeding and infection continue to be at risk with the surgery as well. The final surgery we'll discuss is the laparoscopic duodenal switch. It is both a restrictive and malabsorptive operation. You'll see, looking at the picture on the right, it is both a combination of the sleeve gastrectomy as well as an intestinal bypass. This is actually the best weight loss surgery that we can provide. However, there are a lot more rules to follow, essentially, for patients to ensure healthy weight loss in the long term. On average, we can expect patients to lose 80 to 90% of their excess weight at 18 months. And this is continued long term, as we see 70% of the excess weight remains off at 15 years after the operation. What are the pros? As discussed previously, it is the greatest long-term weight loss surgery that we provide. Your overall ulcer risk is roughly the same as that with the sleeve gastrectomy, and therefore the marginal ulcer risk that we see with the gastric bypass is eliminated. There's typically less food intolerance after having the surgery. The cons show significant malabsorption. This is where patients play a much larger role in their post-operative process in essentially caring for themselves after the surgery. Because there are many more extra vitamins that typically are required, this can become cost prohibitive to some patients, as it can cost upwards of $100 per month. Malodorous gas, or an overall increase in the average number of bowel movements per day, is typically seen with this surgery as well, as the food and fluid that you eat passes much more quickly through the GI tract and into the colon. This can oftentimes be worsened by eating fatty meals, and kidney stones still remain a possibility due to altered calcium absorption from the surgery as well. What are the complications? Overall, we see just potentially higher risks across the board after having the surgery because of its extensive nature. The risk of death and risk of leak are still present. Infection, bleeding, stricture, like we talked about before, and the more important ones that become a major factor with the surgery is the potential malnutrition that can be caused by bypassing large segments of the small intestine. This can result in liver damage or cirrhosis and require essentially refeeding options with IV nutrition therapy if needed. Pulmonary embolism or blood clots in the lungs remain a risk, and reflux or heartburn remains a potential post-operative risk similar to the sleeve gastrectomy. This slide looks at the overall patient satisfaction that patients throughout Michigan have reported by procedure. So as an example, the most commonly performed surgery that we do here at North Ottawa Community Health System is the sleeve gastrectomy. Looking at the combined data from patients that report being at least very satisfied or somewhat satisfied with the results, of the sleeve gastrectomy, this adds to roughly 97% of patients. And we've obtained this data in the state of Michigan through our Michigan Bariatric Surgery Collaborative. We're actually the only state in the country that has a statewide registry that meets regularly and reports this data so we can improve our processes and improve our outcomes. The preoperative preparation for all of the surgeries does entail a preoperative diet. And this is designed around a structured, low-calorie protein fast. We do this to help reduce the size of your liver. Most patients that are obese or overweight typically have fatty liver disease or an enlarged liver. So we actually design this diet, which is not strictly liquids. There are some other programs that require liquids only to help reduce the size of the liver. This gives me or allows me more room inside your abdominal cavity to complete a safe surgery, which equals less risk for you. We also like to see just general improvements, hopefully, in your exercise tolerance. So anything you can do starting today, prior to your operation, this is not a requirement, but does overall increase your potential heart and lung function. This can make the surgery safer as well by reducing your anesthesia risk and build potential muscle mass that can result in greater amounts of weight lost after the surgery. Most patients will have a multitude of preoperative tests performed. And this can be very individualized based on your current health situation or status. Typically, lab work or blood work is performed in addition to EKGs. We typically like patients to have all of their routine cancer screening up to date, such as colon cancer screening with colonoscopy, which I do perform and can do in combination with our upper endoscopies, which I'll talk about next. Cervical cancer screening, breast cancer screening, prostate cancer. Sleep studies may need to be performed if you're at high risk or have symptoms consistent with sleep apnea. Dietary and or exercise education oftentimes needs to be performed per your insurance requirements as well. If you have had any testing or procedures done in the last 6 months, we will ask you to bring this or make this available to us at the time of your first appointment so we can ensure not to double up on any testing. And having a complete medication list available helps us tremendously as well. One piece that we have moved to performing routinely on all bariatric surgery candidates is an upper endoscopy. This is also called an EGD, or an esophagogastroduodenoscopy. We do this routinely to look in patients the esophagus, stomach, and the first part of your small intestine to evaluate for any pre-surgical conditions you may have and not be aware of. This can be gastritis, ulcers in the stomach, even small polyps from time to time. And we especially want to identify if you could have what we call a hiatal hernia. A hiatal hernia is a weakness in your diaphragm. The diaphragm is your breathing muscle that travels up and down every time you take a breath and separates your chest from your abdominal cavity. A hiatal hernia exists when the top part of the stomach that's connected to the esophagus can slide up into your lower chest. This can cause heartburn or acid reflux, and in some patients may actually be silent and not cause these symptoms at all. If we identify this, we oftentimes plan to fix or repair this at the same time as your weight loss or bariatric surgery. This typically adds an extra 20 to 25 minutes to your operation and can be done at the same time with all three of the major operations that we perform. Who's considered a candidate for weight loss surgery? Like we discussed earlier, having a BMI of greater than 35 with at least one medical comorbid condition, or a BMI greater than or equal to 40 is your primary candidacy evaluation. If you don't meet that, or if you have not attempted a preoperative weight loss, if you're smoking, if you have an uncontrolled mental illness, or if you've struggled with substance abuse within the past 6 months, or had a heart attack, stroke within the past 6 months, you may be denied for potential surgery. This is not a complete list. Postoperative success often is greatest when we have patients that are greatly committed to the process. Having that support network in place, having appropriate follow-up, and meeting your follow-up requirements with the clinic, following proper nutrition, exercise, and even attending support groups. And these are oftentimes held the first Tuesday of the month, both at 12 o'clock and the third Monday of the month at 6 p.m. These can be attended even if you're just considering weight loss surgery and want to find out more about what the patients may have experienced during their surgical process. Avoiding pitfalls can be hard. Sometimes this is where patients will have seen that failure rate that we talked about earlier, or approximately 10% of patients may regain some or potentially even all of the weight that they've lost. This can be done by avoiding these high caloric foods and beverages, remaining active, don't isolate yourself, and don't return to smoking if you've previously quit. Oftentimes smoking or tobacco use is accompanied by other bad behaviors and vices such as drinking alcohol or eating certain types of unhealthy foods. This is a picture of our staff, all the way from exercise physiologists, or physician assistants, office staff, medical assistants, a bariatric manager. Our wellness and commitment plan does consist of a $250 program fee. You typically do at the time of your surgical consult. This is designed to cover all of your follow-up care for that first year, which includes typically dietitian appointments and exercise physiologist appointments, as these are not commonly covered or paid for by your insurance plan. Next, we have a series of pictures that show before and after their patients having bariatric surgery. You'll see here that Anna had surgery in 2012 and has lost 180 pounds. Paul had surgery in June of 2012 and lost 135 pounds. Kim lost 183 pounds in May of 2014. Robert and Molly are actually a husband and wife team that together lost 280 pounds. Donna lost 145 pounds in January 2015. Brian lost 110 pounds in March 2015. Gloria lost 127 pounds. Justin lost 130 pounds in September 2000. Brandy lost 145 pounds in November 2015. And Lori lost 105 pounds in June of 2016. Shauna and Brittany had surgery in 2016. This is a mother and daughter team that lost 224. All of the services that we discussed previously, both laboratory testing, preoperative screening such as the upper endoscopy, are all performed right here at the North Ottawa Community Hospital. We have excellent facility, kind and helpful people with newly appointed individual or private rooms that all patients will utilize after their surgery. We also have everything from retail pharmacy with our dietary food choice selections, rehabilitation and fitness consultants, nutritionists, behaviorists, and financial counselors. So what are the next steps? Completing all the paperwork that the clinic will provide to you is necessary at the time of your first appointment scheduling. Typically, we do want you to contact your insurance company privately to understand the specifics of what your plan or policy may require of you. Please know that we also can assist during this process if you have any questions or feel unsure about knowing what your requirements are. After viewing this presentation, you may call the office to schedule your first appointment at your convenience with Dr. Jennifer Sandy to serve as your initial appointment with the bariatrician. At this time, a complete history and physical will be performed, and this is typically followed by a visit with the behaviorist and finally surgical consultation with myself. This is a list of our contact information. I will state a few additional items that most patients tend to ask after reviewing this seminar. Many patients want to know what can I expect for after surgery as far as time off of work and what my potential restrictions may be. I typically tell patients that a 20-pound weightlifting restriction should be in effect for that first 2 weeks after surgery. This is to help ensure that you're healing well, the incisions have an adequate chance to heal, as well as the operation that we performed. Most patients typically will want to take at least 2 weeks off from work. However, this can be altered based on what your potential work requirements may be. If you do have a more sedentary or desk-based job, returning to work in as little as 4 to 5 days is definitely reasonable, as long as you're able to have liquids available with you at all times to drink. Drink your protein shakes throughout the day for that first 2 weeks after surgery, and be able to get up and walk and move around frequently. If you do have a more strenuous job where you're routinely required to lift heavy objects or weights throughout the day, taking that full 2 weeks off of work is definitely recommended. Speaking more about the post-operative liquid diet, this is our typical requirement for all patients having any of the weight loss surgeries, which is at least drinking 64 ounces of clear liquids, non-calorie containing clear liquids per day, in addition to 60 to 80 grams of protein. This is commonly taken in by pre-made protein drinks or shakes that can be made with items that you've purchased prior to your surgery and have pre-identified as adequate in taste. This ends our presentation. Thank you very much for listening, and we hope to see you soon at the North Ottawa Community Health System Bariatric Clinic. Thank you.